So the Judith Herman 3-phase trauma recovery model is the model that I want everybody to have an understanding of and to take away that principle today. The biggest misconception is that you have to do the phase 2 stuff, the processing, the integrating, the looking at the trauma memories in order to get over the situation and to resolve them. Massive misconception that that's the only trauma treatment. If you Google treatment for trauma, all that you will get is screeds and screeds and screeds of stuff about trauma reprocessing and getting in and trying to do something with those trauma memories. It's not always possible. Individuals are not always robust enough to do that, and you can actually get a very good clinical outcome from simply calming the meerkat down, which is phase 1, establishing physical and emotional safety. And if you do enough of that, make sure the individual has safe relationships, a lot of choice and control. If you do that for long enough, and if you do enough of that with as good quality of that kind of work as you can, then the person can move on to phase 3, which is working out what's going to be their new normal in life. How are they going to reconnect with themselves, other people, and the world? And a good quality of life can be achieved with partial symptom reduction and making reasonable adjustments and maintaining emotional safety for many individuals, because they're simply not going to be robust enough to do the phase 2 stuff. Movement between those phases is to be expected clinically as well. People will move back and forward, usually between phase 1 and phase 3. They might do tiny little bits of phase 2 sometimes, but they'll mainly go between phase 1 and phase 3, depending on what life throws at them and how robust they feel. And the NICE guideline echoes that as well. It very, very specifically outlines: build in extra time to develop trust with the person, increase the amount of therapy sessions that you might need, take into account the environment, so it's thinking biopsychosocially, help the person manage issues sort of round about the trauma problem, that anything else that might be happening in terms of their emotion regulation difficulties, and plan to do work with them in the future, because you'll probably only get partial symptom reduction.
So very much the same look for horses, or 3-phase. So the longest phase is likely to be phase 1, and I think this is a bit that horse owners, again, it's the kind of culture in equestrianism of get on with it, do stuff, face your fears, get your horse over his fears, you know, do stuff basically. And if you've got a horse suffering from some type of trauma, leaving them alone, helping them to feel as safe as possible, emotionally and physically, and give that time, give it as much time as it needs. That can be a really hard thing to do, and you're quite likely to have other people on your yard saying, why aren't you riding him yet? Why aren't you doing this? Why aren't you, you know, getting on with it? Also quite hard for us, because we want to actively help, and sometimes actively helping means leaving the horse alone. Sometimes people are aversive to the horse.
One of the parallels perhaps to consider as well is that in humans, when we have people with post-traumatic stress disorder, complex post-traumatic stress disorder, for example, a lot of the time with a diagnosis, the aim is that you look for treatment and you want the problem to be fixed. With formulation, you take much more of an approach of understanding about how this is going to change your expectations, and how do you find a quality of life that looks different perhaps from the quality from the life that you had before. So you might not do the same things, but you adjust to what's different and what's going to be normal for you in the future, and nobody knows what that's going to be. That emerges. So it sets up a slightly different expectation. A very medicalized model of treatment of PTSD often can do a lot of damage, because you try to treat somebody and you try to get them back to exactly the same functioning that they were achieving before, which is often just not realistic.
And I think, again, the tendon injury analogy is quite appropriate here. If your horse has had a tendon injury, you maybe adjust your expectations. You maybe say, he's not going to jump those jumps anymore. He's not going to, you know, there is stuff we won't do with him because he has a weakness there, a vulnerability. So we'll change. We'll, you know, we'll do other stuff. So it's not that dissimilar.